All right, so I foolishly thought I could do this video while I was on shift at a fire department. So I just got off my 48-hour shift not that long ago, and yeah, that didn't work out. Too much noise and stuff. So without further ado, let me go into some of the questions. I did five because I feel like, five questions, that's a pretty quick evaluation to see exactly where you stand. When I make these registry style questions, it's literally registry style. It's me making them. I'm making up the questions based off of my experience, based off of what I've heard students come back and say. So this is test item stuff. I also do it based off of the any sort of guidelines, AHA standards, things like that. So obviously, this isn't going to be specific to where you live or SOPs or protocols, and none of your test items should put that into consideration. Because when you're learning, you learn from general guidelines, and then when you get your license, then you'll learn specifically what your state and what your service wants from you. So without further ado, here's your first question. So you have just should have put delivered, a term baby who is not crying and has minimal movement extremities. What's your first priority? All right, so I got some good answers in there, I think, some good distractions. Suction with the bulb syringe, dry stimulate, evaluate, positive pressure ventilations, chest compressions, blow by oxygen. So if you want to take this real quick, you can just hit pause, but I'm going to go into what everybody answered on the test. I had like 60 respondents, so to me, that's pretty good scoring. So here's the big answers. Yeah, everybody, 80%, phenomenal. If you got that correct. That's awesome. This is what's called neonatal resuscitation program guidelines. There's a ninth edition that just came out. And I understand where some of you guys got the suction with bulb syringe, like, well, that's what I've been taught and all that. Yeah, we used to teach that as soon as they come out, you suction with the bulb syringe. But now, if they're term, they're not crying and stuff, we really want to dry stimulate. We can clear their airway, but we're really just kind of wiping off the airway unless you see something pretty obvious you don't want them to breathe in. We're really not doing aggressive suctioning with bulb syringe just yet. We're going to let them try to breathe on their own. That's why we want to dry stimulate and evaluate for 1 minute. And then we can start doing like suctioning with the bulb syringe if we need to. Then bagging them, giving them 5 breaths, and if that doesn't work, we can go to oxygen, and there's all sorts of stuff that we can do if you go down the NRP 9th edition guidelines. But the first thing we want to do is make sure that we're at least drying, stimulating, evaluating them, because that first minute of life, they're going to have a lower SpO2 than you would expect. I would always ask my students, what SpO2 do you expect the baby to have? And a lot of them would say like 95 to 100%. It's like, no, they'll probably be in the 60s or 70s because they've never breathed ambient air just yet. So they're getting used to this. So this is a new sensation for them to be out of the womb. So the first minute of their life, we're going to be doing drying, stimulating, evaluating them, keeping them warm, getting them close to mom, especially if the baby starts crying and starts making a lot more movement and stuff. When it comes to any registry style question or really practice in general, if you'll notice, it's about triaging your priorities, making sure that you're doing the next thing correctly. So we're not supposed to be robots, but we do need to think in the context of algorithms. So when it comes to algorithms, that's what they're there for. You're supposed to do step by step. It is a little bit cookie cutter when you're learning this world. After you've been out in the world a little bit and you've gained some experience, you'll then know how to shape and reshape that algorithm that fits the best need for your patient. And that's where a lot of critical thinking comes into play. So good job, 80%. I'm happy with that. All right. The next thing is, what signs, symptoms do you expect to find a patient suffering after suffering a myocardial infarction or heart attack? Choose all that apply. And I screwed up on this one. I should have put an answer that I didn't put on here, but I'll pause if you haven't done that, and you can, because I'm getting ready to go over the answers. This is what everyone put for the answers. Dyspnea, heartburn sensation, nausea were the correct answer. So if you got that, great. The crackles and rails I should have put on there too. That's my fault. I should have put that as a sign that you would get from patients suffering in MI. What you wouldn't expect to see is right shoulder pain. That's usually referred pain coming from some type of like maybe gallbladder obstruction or something like that. Headache, generally wouldn't see that with MIs. And here's where signs and symptoms are super important. It's the most common signs and symptoms. I had a patient one time who was having a heart attack and they were complaining of a headache too. So everybody with a headache is also having an MI, and vice versa. And that's just not a general presentation. That's not what we would see every time. And all of this stuff you wouldn't see every time. Some of the worst heart attacks I've had did not have any dyspnea, did not have any nausea. They had heartburn. They had heartburn, or they had jaw pain. They really didn't have any other presenting sign and symptoms. This is just stuff you expect to find. And the registry is really good about making sure you can collect signs and symptoms and overlap them with presenting problems. And that's a really important thing to do even out in the field, so that you can say, well, I've been having some jaw pain for the past 2 days and it hasn't really gone away. So, you might have a high index of suspicion, like, well, how old are they? Do they have comorbidities? Are they on other medications? Do they have any other presenting symptom that may make you think this might be cardiac in nature and not necessarily dental for that particular case? You may only have one sign or symptom. You may have dyspnea. I'm just having a hard time catching my breath. And then you put them on a 12-lead ECG, or the paramedic does, and they find, oh man, this person's having a STEMI, ST elevation myocardial infarction. So don't get hung up on just one presenting sign and symptom. Go with all the expected ones you expect to find. Again, some of these ones that you wouldn't expect to find in heart attacks, you might get that rarely and randomly, but that's still not an expectation. Here's one. What findings are most consistent with CHF? Choose all that apply. And I like all these. I know a lot of people don't like the choose all that apply answers, and I completely get it, but that's the way of testing. It's how things are going to happen. So you can pause real quick if you want to see. If you don't want to see the answers, want to answer it for yourself. But here are the answers that everybody chose. So what's consistent with CHF? Fever or chills is not really consistent with congestive heart failure. They may have sepsis leading to CHF, congestive heart failure, but that's not necessarily a consistent or presenting finding. What I chose was like nocturnal dyspnea, orthopnea. So they get more difficulty breathing at nighttime when they're laying down to go to bed. Or orthopnea, which means that they have more shortness of breath whenever they're in the supine position or laying down position. That's why they like sitting up. They may have jugular vein distension. They definitely will have crackles or rails. Pleuritic chest pain is very specific type of chest pain. It should be always treated as if they are having an MI, but a lot of times we see that with our pneumonia patients. But in this case, it could be pneumonia. It could be an MI. Chest pain is chest pain as far as EMS is concerned, and so we're going to treat it regardless as angina. The other one is rhonchi. If you'll remember what rhonchi is that turbulent noise that indicates thick mucosal secretions, not necessarily wet lungs. It's more of like if they got that dry, raspy, like they need to cough really bad. It's usually due to migrating upper respiratory infection that's now causing hypermucosal secretions. Not saying they're not having CHF just because they have rhonchi, but it's not a general and consistent finding you'd see with patients who suffer from congestive heart failure. All right, here's another one. You're on scene, you find a sleepy appearing child. I'm seeing my grammatical errors. Following a witness seizure. What's your first priority? So this is probably going to trip some people up. And again, I like the first priority questions because it's like, okay, you don't have any other information. This is what you see. You walk up, you have a sleepy appearing child following. This is a witness seizing event. You have no other information. So you have nothing else to go off of, which is such a bummer. But that's what happens. It's like, what's the first thing you should do? So, and you can hate the answer choices, love the answer. It really doesn't matter. But let's go through them. So you can pause right now. Here's the answers. So a lot of people chose oxygen, which I completely understand, and airway, because the trope is, if oxygen or airway in the answer, that's usually what it is. Like, no, not necessarily. Look at the context of the patient. Look at the context of what you're doing. So the first thing you do when you get on scene is you see a sleepy appearing child laying on the ground. Well, how did they get on the ground? We don't know. But we do. They say, well, we don't make assumptions in the field. Yes, we do. We absolutely make presumptions. There's no other information. So the best thing we need to do is we're going to manually stabilize their C-spine. That's the first thing we can do. And you know what we do when we do that? We also get a chance to look at their airway. And we can secure their airway if we need to. Jaw thrust maneuver would be the preferred technique, especially if we think that it's a C-spine. Precautions are necessary. We're not necessarily going to immediately give them high flow oxygen. We don't even know if they need it. We don't know if this patient's postictal. We don't know anything else about the patient. How would we give high flow oxygen? We don't know what their airway status is just yet. How about open the airway and insert a simple adjunct? That's not, I mean, that might be appropriate for this child. Absolutely. But the first thing we're going to do, our first priority is C-spine precautions. Yes, we will find out how long the seizure lasted, but that's, again, that goes way beyond way after the airway, breathing, circulation, the primary life threats evaluation. Obtain a baseline set of vital signs. Yes, we're going to do those. That's not the first thing we're going to do. We're going to evaluate the patient's pupils. And here's the thing, when it comes to doing this stuff out in the field, a lot of times you'll start doing all this stuff kind of at the same time. There's a few things here I'm like, oh, you could probably get this in one fell swoop. You could hold their C-spine, open their airway, ask a parent how long the seizure lasted, and have someone look at the pupils real quick. You've checked 4 things off the list. You're like, man, that's great. But that's not what we're talking about. We're talking about what is your first priority? What's the first thing you need to do before we start moving this patient around? Because if you start moving this patient's neck around and they fail, and that's the only thing, we don't know enough information. And actually, I feel like that's more realistic with EMS. Like, imagine going to a daycare or a school or a church or somewhere or a park where parents call or bystanders call and say, hey, there's this kid that's on the ground, they were seizing, and they don't know how they got there. Well, we have to make the presumption that it was a traumatic event that caused that. So, of course, we're going to first manually stabilize their C-spine, and then we can start evaluating airway, breathing, circulation, and other life threats. Again, you don't have to like the answer choices. It's just something you have to think about. I think this is the last one. So, you got a 58-year-old male, confused, pale skin, vitals are this. Which of the following should be the next action? Again, I like priority-based questions because when you're an EMT, advanced EMT or paramedic school, you're kind of lulled into this false sense of confidence when you're on clinical rotations because you're usually the third person there. You're usually not the person in lead. Even if they do give you charge, you got 2 other people who are going to be behind you, making sure that you're making the right decision, coaching you through it. So you don't really have the independence and the autonomy that you're going to have on the ambulance whenever you're released and you have to make all of these decisions. So it's important for us to know, do you know what the next priority ought to be? So if you look at this, if you remember your checkoff sheets and all that stuff, your scene size up, primary assessment, if you've already gotten all the way down to blood pressure, you've already checked out airway, breathing, and circulation. And again, I can hear people going, well, you can't make assumptions. Like, yeah, you can. They've pale, cool skin, he's confused, and he's got vital signs. So when we look at this, there's going to be some really interesting answers, and I'll let you pause it because here are the answers now. Okay. Most of y'all got this correct. So if I was doing this in class, I wouldn't even really go over it because we don't just apply oxygen just for giggles. It's high flow oxygen via non-air breather. Why? He's 97% on room air. Do we obtain a sample history? Yeah, at some point. Yeah, sure. Open the airway. Why? It looks like it's already open. If we have a good room air SpO2, he's got a respiratory rate of 22. The assumption, let's say presumption, is that his airway is open. There's nothing indicating that there's a tongue in the way. There's nothing indicating that it needs to be open, otherwise suctioned or anything like that. So open the airway is not necessarily the best answer. We got to start figuring out what the heck is going on with this guy. Well, he's obviously got something going on that has something to do with his skin being pale and cool. Could be a low blood pressure, but it's not. His heart rate's a little elevated. So next thing we could do is perform a blood glucose check because that's something that we can identify rather quickly and do something about. So I know a lot of people get frustrated with the registry. I know people hate the registry. I actually don't. I think it's nice to have a standard that everybody gets measured against in order to become an EMT. It doesn't mean that you're going to be a stellar EMT. It doesn't even mean you're going to be a great EMT. It also doesn't mean you're going to be a bad one either just because you can't pass the thing. But it does mean that there's at least something in there that makes you have a foundation of knowledge and that you can prioritize that knowledge so that you can put it out on the test and you can make sense of it. And the people who like to self-diagnose and say, oh, I got test anxiety and stuff like that, I'm like, I don't think you do. I think it's a competence and a confidence issue. Like you start getting on these national registry test questions and they start wearing you down because you can go anywhere between 80 to 120, 130 questions, whatever it is. And they're hard. These are very, very challenging questions. But I would say in the light of working 911, that is a very meager opportunity to demonstrate your competency. And this is the perfect way to do it. So I'll keep trying to put these out. I like to do them in 5-question, 10-question increments, just because I know I tend to get a little long-winded. Hopefully it helps. If you need more, I have more questions and more resources on my Substack, so feel free to check those out.